Hello. Oh, we got Renee here too. Okay, great. Welcome. What we'll do today is we'll finish off. I forgot to include vestibular disorders last time, so we'll do a quick rendition of that. The last page of your inner ear disorders is what we'll look at right now. I'll share screen and see if I can find that puppy on my own computer here. And there we go. We got inner ear. Yeah, the very last page where it says a word about otoacoustic emissions. Put a star by this here too. It's a OAEs are something that audiologists do, and they are actually like the ear working in reverse. It's actually a byproduct, OAEs, when you think of the word oto, ear, acoustic, sound, emissions coming out. So the ears, the cochlea is actually producing sounds. And this production of sound comes from the outer hair cells. As you may recall, the outer hair cells help the inner hair cells pick up soft sounds, and they sharpen the peak of the traveling waves. And so therefore they put off a byproduct. Just like working hard produces sweat, well, that's a byproduct of work. Like a light bulb produces heat, well, the heat is a byproduct, okay? So OAEs are a non-behavioral test of outer hair cell function. And actually it's a probe stuck in the ear, and audiologists will measure if there's sound actually coming out of the ear. And I'll see if I can. I don't believe I have the picture of it. I'll see if I even do, just for the sheer heck of it. Why don't I just see if I got me a picture of it? And my good old OTC notes. Pull this guy up here, looking 125, and oh, look at that, all your quizzes and everything in there. Look at that. Oh my gosh. Oh, what have we here? Oh, I know what I want. I want this guy here. And let's look at inner ear disorders and see if I got a picture of the probe used to test OAEs. I just might. So here we go. That's if I've got my act together. If I don't, oh yeah, here we go. Lucky, I did. So there's a picture of it, a probe stuck in an ear canal, and you're producing a couple of sounds. You look at this F1 and F2 you'll see here, okay? That's frequency 1 and frequency 2. And they have to be separated by a certain amount. Now, you don't have to know this because you're not doing this in your practice, but I want you to know basically what this is. They'll split the tones by a ratio of 1 to 1.2. So that means if tone 1 is 1,000 hertz, tone 2 is 1,200 hertz. If tone 1 is 2,000 hertz, tone 2 is 2,400 hertz. And they split them by a certain ratio. Nonetheless, who cares? They put them in the ear at the same time, and what comes back is a third tone called DP. That's your distortion product. That's your otoacoustic emission. Now, we can't hear these, okay? See, here's another picture showing you F1 and F2 put into the ear canal. Here's the noise floor in your ear canal. And when you put two tones in separated by that certain ratio like that, you get certain tones coming back. And those are otoacoustic emissions. And if you don't have outer hair cells, you won't have OAEs. If you have a hearing loss, you probably won't have OAEs. If you have mild to moderate sensory neural loss, you have outer hair cell damage. So you won't have OAEs. If you have middle ear pathology, then the middle ear pus, the middle ear infection, is going to prevent the passage of OAEs from getting picked up. So here's the picture of what's happening. See, here's speaker 1, speaker 2. This is the probe stuck in your ear. And the two tones, F1 and F2, go through the ear canal, through the middle ear, into the cochlea, and the outer hair cells produce that distortion product that goes back through the middle ear, back through the ear canal, and gets picked up by the mic in the probe. Far out, huh? So anyway, that's oto, and they call it DPOAEs, distortion product otoacoustic emissions. So here's the picture of the probe. This is just a picture showing you basically what's happening. And what you're picking up is your otoacoustic emission. So this is me some time ago, okay? Look at the noise floor in my ear canal, nice and soft. Here's the otoacoustic emissions picked up across the frequency. And at that frequency, look at that, the OAE is way above the noise floor. And sure enough, when the two tones are put in the ear, there's my OAE. But when they checked at this frequency, now when the two tones are put in the ear, guess what? There's no OAE. It's gone. So it's indicating that TED has hair cell damage at the very high frequencies. See? OAEs are a means whereby to test infants, babies, and people who can't talk to you, people who want to lie in a hearing test. OAEs. Babies and infants, OAEs. Very, it's just something I want you to have heard of, but enough on that. That's this story here. Okay, now let's look at vestibular disorders. And we're not balance experts. You and I are not testing balance experts, but we need to know a few basic things about vestibular disorders before we go into retrocochlear pathology. Remember, the purpose of the vestibular system gives your brain an awareness of where your limbs are in space, where your balance is. Remember the 3 legs on the stool. Okay, a stool needs 3 legs to stand. There are 3 parts to your balance system. One is vision. The second one, the inner ear, the balance organs. The third one is what cops test when they suspect you of a DUI, the Romberg test, and it's called proprioception. P-R-O, P-R-I-O, proprioception, C-E-P-T-I-O-N, proprioception. And it's an awareness of where your limbs are in space without you looking. So they'll ask you, and I'll stand back so you can see me here. They'll ask you to stand there, put your arm out, close your eyes, and you have your eyes closed, touch the tip of your nose. Can you touch the tip of your nose? Well, if you're drunk, you're doing this. You're missing, okay? Your proprioception is off. It's called the Romberg test. So 3 parts to balance: vision, vestibular system, the ear, and proprioception, knowledge of where your limbs are in space without you looking. Ballerinas have excellent proprioception. Dancers, acrobat people, people who do gymnastics, excellent proprioception, knowledge of where their limbs are in space, really coordinated. Anyway, back to balance. Vestibular system, let's concentrate now more on just the vestibular system. So one of those 3 legs, okay, namely the inner ear vestibular system. So here's that summary that I just gave you here. Human balance system has 3 parts: vestibular system, vision, proprioception, and the vestibular system itself contains 3 parts: the utricle, the saccule, and the semicircular canals. The utricle and saccule, they're not part of the cochlea, as you'll look in your any notes or anatomy. They're next to the cochlea. They're like little tiny bags. They're the membranous labyrinths of your vestibular systems. Utricle and saccule, they tell you linear acceleration. Those 2 little areas tell you whether you're going up and down or left and right. You ever been sitting in a car at a stoplight and you're not sure if the car next to you is moving or if you're moving, and you got to kind of look? See, it shows you that your balance system needs vision, as well as you're not sure what's going on until you check it out. So utricle and saccule, going up in an elevator, and all of a sudden it stops in your stomach. Utricle and saccule, telling you when you're going up and down or horizontal. Okay? Then the third part of your vestibular system is your 3 semicircular canals. And the semicircular canals, remember from anatomy, from 120, they are in orthogonal planes to each other. Okay, 90-degree angle planes to each other. One plane, this plane, and this one. Like the corner of a room. When you're looking up at your ceiling and you look where the walls meet, so if I point right up there, orthogonal means this. Right there. Okay, the corner. Your semicircular canals are exactly like that. They're located at 90-degree angles to each other. You know why? Of course, recall from anatomy. They tell you the location of your head in space, because your head swivels on your neck. It's not like an elbow that only bends one way. Your head can go in any direction. So your 3 semicircular canals, fluid is going to move in one or more of those 3 semicircular canals, no matter how you move your head. And that tells your brain the location of your head in space. So you've got 3 sets of 3s here. I guess that's what I want you to take home. The balance system is comprised of 3 parts. Now let's just look at the one part, the vestibular system. Take away vision, take away proprioception. Now just look at, that has 3 parts. The utricle, saccule, and semicircular canals. And then when you look at the semicircular canals, there's 3 of them. Okay, 3, 3, and 3. That's a mnemonic to take home just so you have it. Okay, share screen now. That's all of this stuff. Don't worry, don't freak anymore about that, but here's your 3 semicircular canals forming orthogonal planes, what I'm highlighting right there, 90-degree angles to each other. What you need to know, don't worry about all of these things here. This is anatomy, this is anatomy, this is anatomy. I'm not going to ask you anything like that in quizzes or tests. But this is what you need to know. Damage to the vestibular system results in vertigo. And circle the word nystagmus that you see there. Nystagmus. What is nystagmus? That is how your eyes follow things to locate your direction. You're sitting at a train track in your car and you're counting the cars going by. Your eyes are going, what, what, what. A ballerina turning around on her heels, her head's going, it, it, it. You're following, snapping back, following, snapping back. Nystagmus, the tracking of your eyes. When they test for vestibular problems, they put electrodes right here and right here, and they get you to watch lights, and the lights are tracking, and they follow the movement of your eyes. Do you have nystagmus? Then they put cold water in your ear, just below 98.6 degrees. They irrigate your ear canal with cold water. That induces nystagmus. Your eyes are starting to go, then they put warm water in that same ear canal, and they watch your nystagmus go in the opposite direction. They're inducing nystagmus. They're making you dizzy on purpose. They're trying to see if your vestibular system is working. Yes, Angela. I can't hear you. I can't, I'm not sure if your mic.
Okay, I was working with a small handicapped child one time, and we were on like a merry-go-round, a small one, and I was just spinning him, and when I got done, he was loving it, but when I got done, his little eyes were going,
yep,
you know, like that. Is that?
That's nystagmus. If you were drunk and you're laying on the bed and you're just about ready to pass out and you're kind of dizzy and you get the bed spins, if someone opened up your eyelids, they'd see you doing the same thing. You're trying to find balance. You're trying to get your act together.
Okay.
Anyway, that's just a bit about the vestibular system. So when you're looking at this kind of stuff here, one of the main problems with the vestibular system, and it's a very common one, almost lots of adults get it. In fact, you and I probably have it to some degree anyway. Remember how when you were a kid, you loved to go on dizzy things and spin around and on these rides at carnivals, and now you don't really like it so much, do you? Huh? Even the thought of it just kind of makes you, my daughter, oh man, let's do it again. Let's go out again. Let's not and say we did. Here, you go ahead, I'll watch. It's kind of like BPV, benign paroxysmal vertigo. Look at your notes at the bottom. BPV. It's very common inside your utricle and sacual and semicircular canals. Recall from 120 anatomy. Remember you had this gelatinous mass sitting on top of the hair cells inside your vestibular system, not the cochlea, in the vestibular system. Like jello, a gelatinous mass sitting on the top of your hair cells. So here's your hair cells all standing there, and there's this thick wad of jello all surrounding them. And on the top of the jello is these tiny little rocks, these little stones called otoliths. When we get older, sometimes those fall off of the jello. They no longer provide that mass on the top of that jello to create that lag, okay? And so the ear stones have fallen off. And then you'll find that when you get your head in a certain position, you're bending to tie your shoelaces, or you're just, and it's kind of, ooh, that made me dizzy. Ooh, whoa, 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 whoa. And it's only in that certain positions that my mother told me, my 93-year-old mom told me yesterday. Well, we were talking, and she said, yeah, Ted, every time I turn on my right-hand side in bed, when I turn over to the right, I get dizzy for a little bit. I said, it doesn't mean anything, Mom. It's just ear stones have fallen off. Just, if you look in your medical books, because she always reads it, look for BPV. It's the most common vestibular disorder. Okay, it's what doctors do, ear, nose, and throat physicians, and some audiologists. Okay, they learn to position a client's head in order to allow those ear stones to fall back on top of the jello again. Okay, they call it positional, treatment for vertigo. And they learn to, have to lay back, and they'll turn your head this way, and then they'll have you sit up, and they're doing all these weird things to get those ear stones to fall back where they belong. So again, benign, meaning it's not cancer, won't kill you, it's just a nuisance. Benign paroxysmal vertigo is the most common vestibular disorder. And you can read it right there. Okay? Especially when you turn your head in certain directions. Ear stones have fallen off. ENT physicians have to know how to position head to try to get these back to where they should be. When I talk to you about the lights, your eyes tracking with the lights, that measurement is called electronystagmography. ENG, electronystagmography. So you now know the most common balance problem. You know the acronym for it, benign paroxysmal vertigo. And you also know what the name of the test is when they're testing for vestibular dysfunction, electronystagmography. They want to induce nystagmus because it's normal, and that by putting water in the ear or whatever, or by you tracking lights, and they're measuring the movement of your eyes with the electrodes. Electronystagmography. Okay, now we are done that particular one. Let's make that guy smaller, and let's go to retrocochlear. Yes, hang on here. Hang on. Okay, hang on. All right. Angela.
Yes, so when the stones fall off, that is due to an aging process.
Yep.
Just getting older.
Doesn't mean you're not a nice person. Just happens.
I'm sure I've lost my stones.
Oh, yeah, I have too.
When they put them back on, do they stay?
For a while.
For a while.
And
the patient loses that.
Yep. There's certain people get it really bad. I have a dancer friend in Mississippi, and he's a ballet teacher, and he got BPV. And he says, oh man, he goes, just a certain, when I put my head in a certain way. So he went and got the treatment for it, and it made it better. It didn't totally take it away, but it improved things for a while. You know, it's just, I just want you to have heard of these things, because we're not doing it, but we're in a related field. So when you see in a letter BPV or you see ENG, you should, oh yeah, balance, those are balance tests. That's the vestibular disorders. That's the purpose of me talking about this here, because we don't do this in our daily lives. I had to do it in grad school in audiology, but that was a long time ago, and the test was always done on Mondays, and we called it Dizzy Mondays. It was, oh God, I'm glad I'm not involved in it anymore. It's like, enough on that puppy. So here we go. Let's look at retrocochlear pathology. This is a real red flag. When you see the word retro, it means behind. You know, like old-fashioned, right? Retro, hey man, retro looking lamp, man. Okay. Retrocochlear means behind the cochlea. When you have retrocochlear pathology, it's usually an eighth nerve tumor. If it's an eighth nerve tumor, it's benign. It's not cancerous, but it will kill you. You will die. Okay, they have to get it out, because the eighth nerve feeds right into the brain stem. And as soon as that tumor, where does the eighth nerve course through? Remember your 120 anatomy. Think about the eighth nerve. Geez, man, well, you could have combed your hair before you started. Anyway, when you think, sticking up all over the place, great. This is on YouTube for perpetuity. So when you think of the tunnel where your eighth nerve goes through, it's a little tiny tunnel through bone, little thin tunnel. It's called the internal auditory meatus, as opposed to the external auditory meatus, which is your ear canal. Meatus just means tunnel in Latin. Okay, so you have your external auditory meatus, your ear canal. Your internal auditory meatus is the tunnel through the bone that your eighth nerve goes through, from your cochlea to the brain stem. And what's the brain stem? Your spinal cord inside your skull. That's what your brain stem is. So as soon as your spinal cord enters the base of your skull, now it's called the brain stem. And you have 12 pairs of nerves connecting to that, don't you? They're called the cranial nerves. And the 8th pair is the auditory pair. Okay, you have the 5th pair, the 7th pair. They're involved with the acoustic reflex, and we're not caring about those right now. It's the 8th cranial nerve. 1 inch long. Okay, it's the shortest of all your 12 pairs of cranial nerves is your 8th cranial nerve. And it goes from the cochlea and balance organs to your brain stem. If a tumor grows on there, it can't grow wide because it's in the tunnel. Just like the refill in this pen fills the pen, okay? There's not much room in there. But as soon as it's able to leave that tunnel and get to the brain stem area that's going like this, okay, all of a sudden it's like the tumor's in la-la land. Now it's happy because now it's out of that tunnel and it can grow like crazy because the brain stem is soft. And it's going to push the whole brain stem. It'll just bend. It'll get as big as a baseball, okay? So it'll kill you. So yeah, they have to get that out. So audiologists use a test called the ABR, Auditory Brainstem Response. We'll look at that more as we're talking in the notes. I'm just kind of giving you a headway. That's done with electrodes too. And they put electrodes on your ears and one on your forehead and one at your hairline for a ground. And then they put headphones on and they produce sounds. And they're looking for brain waves. Then they'll try to the other ear. And if the brain waves aren't in the right place, 8th nerve tumor. Did I show you the 2 little feet I got for my birthday? This has got nothing to do with anything. But my wife takes care of Syrian refugees here. She does volunteer work, and one of the kids, it was my birthday the other day, so somebody gave me these feet. Just thought I'd show you. It has nothing to do with retrocochlear pathology, but it's these little feet that I had. So, okay, so share screen here. Let us go to retrocochlear, and let's make sure we have some terms. Retrocochlear here refers to pathology of the eighth nerve or brain stem. In other words, the stuff behind the cochlea, hence the term retro. So your central nervous system, put a star by this, remember this from anatomy, your central nervous system is comprised of your brain and spinal cord. Okay? All other nerves are part of the peripheral nervous system. Okay? So your CNS, brain and spinal cord. So your brain stem, spinal cord, all the way down your back, okay? That's your central nervous system. Peripheral nervous system, as I highlighted here in gray, is everything else. So if I asked in a little quiz, the eighth nerve, is it part of the central nervous system or part of the peripheral nervous system? Some might be tempted to say, well, it's in the head, so it's got to be central. Is it the brain? No. Is it the spinal cord or brainstem? No. Well, then it's the peripheral nervous system. So your retrocochlear pathology involves the eighth nerve, which is part of the peripheral nervous system, or brainstem, or auditory areas. We're talking about auditory stuff behind retro to the cochlea. Remember this stuff too from anatomy. This is all repeat from 120 that you've had in anatomy. You've got 4 terms there: nerves, ganglia, tracts, nuclei. All they refer to is white and gray areas. You've got white areas, you've got gray areas, all through your nervous system. Okay, so when we look at it, I'll show a picture here so we can see it more in lovely highlight here. Where are we? Here we go. All right, let's see if I've got a picture here. We can show. There you go. We're getting something. We're getting a few pictures here. Okay, let's look at your spinal cord just for fun. Here's a piece of your spinal cord. We'll blow this guy up a little bit here. So this is just out of the back, the spinal cord, up your vertebra. And notice how you've got nerves going off the sides. Boom, boom, boom. Okay? And notice how the spinal cord is white on the outside and gray on the inside. What are the white areas? What are gray areas? Well, white areas are the tracts. Are like, if I stand back here, the white areas are like my arms. They're the arms of the nerves, okay? They're the axons and the dendrites, remember, from anatomy? And the gray areas are the cell bodies. So neurons have a cell body and then arms. And the cell bodies are gray. And the white is myelin. It's fat. It's like insulation. I don't have... If this was an electrical wire here, okay, it's the rubber on the outside of the wire, okay, and it's white. In the nervous system, the axon is, what do you call it, lined with fat, myelin, and that's what insulates the nerves from each other. Just like electrical cords, they got the rubber on the outside so they don't short. Okay, so if you have electricity going straight through 2 wires and you cross the wires, zzz, okay, that's what epilepsy is. Okay, multiple sclerosis, MS. You are losing the white fatty myelin, M-Y-E-L-I-N, myelin. In the nervous system, it's called myelin. Some people get put on what's called a ketogenic diet, high fats. Eat your cream, cheese, dairy products, all the fatty stuff to build up myelin to help reduce seizures. Okay, so you have white areas, gray areas. The gray areas are the cell bodies. They are not myelinated. The white areas are the arms of the neurons. So back to your notes here. You've got 4 things in these notes. And in the notes, here they are highlighted thusly: nerves, ganglia, tracts, nuclei. And nerves are simply white matter in the peripheral nervous system. For example, the eighth nerve. Ganglia are gray matter in the peripheral nervous system. And you have an example, the spiral ganglia of the cochlea. The gang of cell bodies. And if you look in your 120 notes, they look like little olives. They even had a pimento. No, I'm lying, but they look like little eyes. And they're inside the cochlea, just outside of the scala media. You'll see these little blebs, little balls, kind of blip, 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 blip. Those are all spiral ganglia. They are the cell bodies of the eighth nerve. So the eighth nerve, remember, is bipolar. It gets really depressed. It gets really happy. No, it's bipolar. Okay, it means it has a body, and then it has one arm going to the inner hair cells, and the other arm goes to the brainstem. Okay, it has two arms. And that's what all eighth nerves are, bipolar cell body with two arms. Not multipolar cell body with lots of arms. No, those are motor nerves. Sensory nerves are bipolar. And the eighth nerve has all the collection of all the cell bodies together. It's gray, and they're called the spiral ganglia. So look in your notes in 120 to review for that, so you have a mental picture of what that looks like. So when you're looking at eighth nerve pathology, we have to know what's normal. What is the eighth nerve? Okay, tracts and nuclei, the bottom two. Tracts are white matter in the central nervous system. And nuclei are gray matter in the central nervous system. So you got white matter, gray matter, central nervous system, peripheral nervous system. You have four different terms, and that reflects neurology. Okay, so all nerves, nerves are not all just nerves. There's four different terms that we use. Anyway, the eighth nerve is a sensory nerve. It carries impulses to the brain, like all sensory nerves do. So it is afferent, A-F-F-E-R-E-N-T. Can you see how you need a lot of 120 anatomy? You have to really keep that course close to your heart to understand retrocochlear pathology. To understand any disorder, you have to know what's normal in order for you to tell what's not normal. So the eighth nerves or sensory nerves are bipolar. Motor nerves are multipolar. What are motor nerves? Nerves that go to your muscles. And those are efferent, E-F-F-E-R-N-T. Remember, it's a two-way street. Sensory goes in, and then what comes out of the central nervous system? Motor messages to contract your muscles. Sensory information to the brain, motor information out of the brain. Sensory information up bipolar neurons to the brain, vision, smell, hearing, taste, touch. All sensory information is afferent, motor information efferent, from brain back out. Well, the eighth nerve is a sensory nerve, so it is afferent. The eighth nerve is the shortest of all the cranial nerves. It's only an inch long. And now let's look at the pathology, and let's look at eighth nerve tumors. What are these guys? Eighth nerve tumors, retrocochlear pathology, the main sign, and let's make sure we know the difference between the word sign and symptom. Signs are seen, symptoms are reported. Okay? So tinnitus, ringing in the ear. You can't see it, you can't hear it, so it's a symptom reported by the client. A sign is seen by you, the clinician. And what is the sign? Unilateral sensory neural loss. Because you'll almost never get an eighth nerve tumor in both ears. It's almost always unilateral. So if you've taken a case history and you've ruled out noise-induced hearing loss, the guy's a trucker and the window's open on the left-hand side, so that might cause more asymmetrical hearing loss. Maybe the person's a hunter, he's right-handed, and the left ear is closer to the barrel of the rifle. So he's going to have more hearing loss in his left ear. That's asymmetrical. But let's say you've ruled that out. You've taken a good case history. Guy doesn't have an ear infection, doesn't have noise-induced loss, doesn't have Meniere's disease, isn't talking about dizziness. A young mother of 33 years old, 3 kids, says to you, yeah, for some reason I just can't talk out of the left ear anymore. I just can't. I don't know. I just can't understand a thing in the left ear on the phone. I've got to use the phone on the right ear. Well, how long have you noticed this? Oh, about the last 6 months. Oh, weird. Well, what would you do? You'd do a hearing test, and you'd find asymmetrical, and then you'd do bone conduction, and you'd find it's asymmetrical. So, asymmetrical sensory neural loss in a young woman, no noise exposure, no Meniere's disease, weird. Then you'd do speech testing, and you'd find terrible speech recognition in the bad ear. Even at a comfortable loudness level, at MCL, you'd still find abnormally. And the hearing loss wouldn't even be bad. Maybe the hearing loss in the right ear would be normal, and the hearing loss in the left ear could be 20 dB, maybe 30. But that's enough to be asymmetrical. Why would you have a difference? No ear infection. Then you did a tympanogram. Normal type A tympanograms, both ears. Okay, so there's nothing wrong with the middle ear. And there's no air-bone gap. It's not like she has a hearing loss through the headphone and then normal hearing through the bone. The loss is sensory neural. She developed it over 6 months' time. That's called a red flag. You refer to an audiologist or refer to an ENT. You cannot fit with hearing aids. Illegal. Okay? Retrocochlear pathology has to be ruled out. The woman may feel no pain, doesn't hurt, it's not an infection. She might have bouts of dizziness once in a while because you're squeezing the 8th nerve, maybe you're getting problems, maybe ringing in the ear at times. Poor speech recognition, and the hearing loss doesn't have to be profound. It could be even slight, it could be mild. Any hearing loss that's more than 15 dB different across several frequencies, and it's sensory neural hearing loss, okay, and it's not conductive, it's got nothing to do with the middle ear, that's a red flag. Refer. Retrocochlear pathology. And you don't know whether it is, but you want to rule that out. So here you go. Let's read about it. 8th nerve tumors are not at all very common. According to Schucknecht, they comprise only 8 to 10% of all intracranial tumors. Break down that word, intracranial. Intra means within. Cranium means the skull. So of all brain tumors that people have, 8th nerves tumors comprise about 8 to 10% of all brain tumors. You should have a handle on that. Another thing you should know is right here where I'm highlighting. What's the prevalence? What's the incidence of it? About 1 in 100,000. So in the city of Springfield, Missouri, which is probably what, 200,000 people, you might have 2 people, 3. So you might have three people with an 8th nerve tumor. So you should circle that. What's the incidence and prevalence of it? Okay, how often is it? About 1 in 100,000. Not 1 in 10,000, not 1 in 1,000, 1 in 100,000 people. According to this, about 20 new cases each year in a city of about 3 million, maybe 30. Okay, in other words, audiologists see very few acoustic neuromas. Acoustic neuroma is another name for 8th nerve tumor. Same thing. Okay? The initial symptom for an acoustic tumor is usually hearing loss in one ear, sometimes ringing in the ear. You can see where I'm graying it out here. Vestibular problems are reported about 3% of the time. So but they can grow, they can be less than 1 centimeter to greater than 2 centimeters in size. And again, what's a centimeter? It's good to have a grip on this. A fingernail. That's about 1 centimeter. Okay? It's always good to put 2.5 centimeters together and you got 1 inch. Don't leave this one here, though. This one's bad. Okay. I just cranked it here. All right, here we go. Renee's going, oh my God. Okay, here we go. So let's look at, they grow at the rate of about 1/10 of a centimeter per year. The tumor size has an effect on ABR and other test performance. In other words, the bigger the tumor, the better the test is at detecting the pathology. The bigger the tumor, the better the test is at picking out the pathology. So let's just talk turkey here, because, gobble, gobble, no, we're nowhere near Thanksgiving yet. So, retrocochlear pathology is the testing ground of tests. Okay, this is where the rubber hits the road. It's easy to do a pure tone test and find presbycusis. It's easy to do a tympanogram and detect if you've got middle ear pathology. But eighth nerve tumors are tiny, and that's where the testing ground of tests. So let's talk about tests, whether they're pure tone, whether they're speech, whether they are urine tests, whether they are tests for, what do you call it, breast cancer, whether you're doing any kidney tests, tests that doctors do, tests that clinicians do. How good are the tests at detecting the pathology? Let's talk in general terms. A test can be 100% sensitive. It means it catches everybody that's got the disease. But guess what? It also caught a lot of people that didn't have the disease. Okay, you were fishing for salmon and you ended up catching a whole bunch of dolphins as well. Oops. You got all the salmon, but you ended up getting a bunch of other fish that you weren't after. Okay? That test is 100% sensitive. It catches everyone that's got the disease, but then again, it might misidentify people who don't have the disease as having the disease. Look at the other side of the coin. And the word here isn't sensitive, it's called specific. A test might be 100% specific, meaning it passes everyone that doesn't have the disease. But then again, it might pass someone who has a tiny little tumor. It wasn't sensitive enough. Okay? So you can have a test that's 100% sensitive or a test that's 100% specific, but each of those are only half of the coin. A test that's 100% sensitive and 100% specific catches everyone who's got the disease and passes everyone that doesn't have the disease. Those tests are rare. They're called gold standards. A gold standard. You want to know an example of a gold standard test really easy? Looking in the ear canal with an otoscope and seeing a tube in the ear canal. Duh, I see it. Okay, duh, it's there. Okay, every time the tube is there, I caught it, and when the tube wasn't there, it wasn't there. Think about testing thresholds, because there's a parallel to pure tone testing. Remember audiometry class 130. You might have somebody who's guessing all the time, right? Remember we talked about this in acoustics class. Mrs. McGillicuddy, she wants to pass the test. So she used to teach first grade. She comes into the booth with her little white gloves and hands on her purse, and she's raising her hand all the time, and you haven't even pushed the button on your audiometer yet. Okay? She's giving lots of false positives, right? And then you might have Herb, who got dragged into the hearing test and didn't want to be there. And he's waiting till he's sure he hears the tone. And when he hears the tone, he's going, he doesn't want to be there. So it's the same thing when you're looking at tests. A test can be 100% sensitive. That's like Mrs. McGillicuddy guessing. It's going to always identify, and it's going to catch. She's always going to raise her hand when she hears the tone, but she's also going to raise her hand when the tone isn't there. Get it? There's the parallel. And it's the same with Herb. Oh, every time the tone's not there, he's not going to respond. But sometimes when the tone is there, he's not going to respond either because he wants to be sure he hears it. You see, that's 100% specific. Every time the disease is absent, the person gets passed. But you know what? Sometimes when the tumor is little, the person gets passed as well. So now let's look at this in terms of our PowerPoint and our notes. So here we are, and this is kind of where we're bringing ourselves today. Look at these terms. A word about tests. How to test a test. True positives. In terms of thresholds, the tone is audible and the person raises a hand. In terms of tests, the person has the disease and the test catches it. Okay, see the parallel? Now let's look at true negatives. In terms of thresholds, the tone is absent and the person doesn't raise a hand. In terms of tests, the person doesn't have the disease and the test passes you. Okay, that's a true positives, true negatives. Now look at false positives. In terms of thresholds, the person guesses too often. Mrs. McGillicuddy raises a hand even when imagining a tone. In terms of tests, the person doesn't have the disease, but the test says he does. Get it? And now false negatives. In terms of thresholds, it's like Herb. The person raises a hand only when he's sure a tone is audible. In terms of tests, the person has the disease, but the test passes you anyway because maybe the tumor was small and the test didn't catch it. So you've got basically 4 boxes, just like you saw in psychoacoustics when you took 110. And we'll go right up to here. There it is. Just like you had in 110 psychoacoustics. Same, okay? But here, it's not tone present and tone absent. Here it's disease present or disease absent. A true positive means the test says you got the disease and yes, you had the disease. A true negative on the bottom right corner, the test passes you and it's a correct rejection. You didn't have the disease and so you passed. But you can also have these 2 boxes when the disease is absent but the test failed you. False positive. Or you can have this box here when you had the disease but the test passed you. Said you didn't, you were okay. This one's the most dangerous. This one will kill you. False positives just make it inconvenient. Oh yeah, you got the disease, you got the disease, and then they do another test and find out that you don't. But it made you have to take an extra day off of work because you had to drive all the way to St. Louis to find out. Okay? So this one's just called a pain in the ass. This one here is a dirt nap. You'll die. Either way, they're false, they're mistakes, okay? And all tests are like that. They're not all 100% sensitive or 100% specific. They're just not. It's like, just like the tone here at 5 dB or the tone at 50. Remember this stuff? I want you to draw the parallel so you see it. If you have normal hearing, let's make that black bar go away. I can't stand this black bar up there. Go away, thank you. So let's say you had normal hearing. And the tone is presented to you at 50. Well, every time the tone is present, you're going to say yes. Every time the tone is absent, you're going to say no. So all your responses are going to fall in true positive and true negative, aren't they? But now look at the number 50, and now let's make it 5. Now the whole test is harder, isn't it? Now your whole behavior is different. Now you're doing this. You've lost your confidence. You've lost your moxie. It's gone. All of a sudden you're squinting because now you're going to test as harder. And so you're going to make mistakes. And that's what we're talking about here when we're testing a test. If the tumor is small, it's hard for a test to pick it out. You may get false positives, you may get false negatives. And so you never rely on one test. That's why. That's why in audiometry, you never rely on just pure tone testing either. You do pure tone air, pure tone bone, then you do speech, then you do tympanometry. And you want them all to point in the same direction, because no test by itself is a gold standard. Get it? That's how medicine works. Okay? That's how doctors are trained. That's what they do. That's why they get all anal about things. That's why audiologists, oh, this doesn't quite line up with that. It isn't quite, yeah, it's got to point in the same direction. So tests, and retrocochlear pathology is really a testing ground of tests, and that's why we bring this kind of stuff up. So if you have normal hearing, go away bar, and the tone is only 5, yep, when the tone's present, you're going to say yep. When the tone is absent, you're going to say no, it wasn't there. But sometimes when the tone is absent, you're going to put your hand up. Mistake. And sometimes when the tone is present, you're going to keep your hand down. Mistake. Okay? That's what we mean when we're talking about sensitivity, specificity. It's the same thing as this. Okay? That's why we draw the parallels. So, if you've got an overlap, clients with a disease, they may end up with a score here. Clients without the disease, they may end up with a test score over here. But look, there's an overlap. And that's the error. That's the false positives and false negatives. It's only when things are perfect, when there's no intersection between the test scores, there's no error. That's a gold standard. No error. No overlap. So I leave you with this, and I will pick up with this again next week, but I just wanted to introduce you to some of these terms here, okay? Because it's really wild. When you're looking at a test, and we'll carry on more next week about this, the best tests are going to be MRIs, magnetic resonance imaging, stuff we don't do. Your tests and my tests will point an arrow in the direction of an eighth nerve tumor, and then we refer. And the guy goes to the hospital and gets an MRI done, and they put dye in you. Now, I'll tell you a little story about this, too. I had a terrible throat infection 10 years ago, way back. The whole throat was bulged, just like, they were going to do surgery. They thought for sure they were going to need to. They didn't need to, but I ended up getting put on intravenous antibiotics and blah, 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 blah. But they did an MRI on me. And I remember they injected me with a needle in the arm, and it had dye in it. And you know why they put that in there? To contrast the white and gray areas. So you can see the contrast between the gray and white areas. And that dye has a potential that you could be allergic to it, so you have to sign something. But at any rate, when I got the dye injected in me, I said to the nurse, "I'm sorry, I think I just peed my pants." She goes, "No, you didn't. No, you didn't. The dye makes you think that." You're the first male that we've ever had that said that. But that test is like a gold standard. That one, because then you're looking really close and you're looking in and they can pick out a tiny little tumor, and that's almost a gold standard. I mean, that's the best. Our other tests that we do are not 100% sensitive and 100% specific. So make sure that we have these terms down. We'll just go up here, back up to where we were here. Have a good read about this stuff. There's two other terms here, validity and reliability of a test. Validity of a test is how accurate is it? Is the test testing what it says it's testing? Is it really? I mean, speech discrimination. Think of that test, speech discrimination. The test you're doing in speech. Say the word cow, say the word tree, say the word light. Okay, lousy speech discrimination could be a sign of an eighth nerve tumor. Then again, could be a language barrier. Duh. Maybe English isn't the guy's first language. You ever think of that? might have something to do with it. So you can see right away that speech discrimination is not 100% sensitive. There's no way. It's kind of like it'll point in a direction, but it's kind of like picking up needles with mittens on. You know what I'm saying? It's not fine. It's better than nothing, but it's a kind of a gross test. Acoustic reflex is a better test. It's better because it's non-behavioral. You think of non-behavioral tests. The guy is responding to you, but you're putting a loud sound in the ear. And remember from last week, the acoustic reflex arc, the loop, outer ear canal, middle ear, cochlea. What part of cochlea? Inner hair cells. Eighth nerve to the brain stem, and then back out the fifth nerve to the tensor tympani muscle, back out the seventh nerve to the stapedius muscle. So you've got that acoustic reflex arc. Eighth nerve tumor, eighth nerve is involved in that acoustic reflex arc, isn't it? How do sounds get from the inner hair cells to the brainstem? The eighth nerve. So guess who's going to have absent acoustic reflexes? Eighth nerve tumor. But then again, yeah, that's non-behavioral. At least it's non-behavioral. Non-behavioral is better than behavioral. But is that 100% sensitive or 100% specific? Not really. Conductive hearing loss also obliterates acoustic reflexes because of pus in the middle ear space. So you can't measure the tightening of those things because the whole middle ear is like, so you can't. So absent acoustic reflexes could be due to middle ear infection, could be due to an eighth nerve, could be due to severe sensory neural loss. Because what dies first, outer or inner hair cells?
Outer.
Outer. So then inner hair cells begin to die afterwards. Well, that's part of the acoustic reflex arc, isn't it? Right? Because it's part of the steps along the path. So if now the inner hair cells are affected, you've got a severe sensory neural loss, but you don't have an eighth nerve tumor. You just have a severe sensory neural loss. Well, you're going to have absent acoustic reflexes too, aren't you? See? So absent acoustic reflexes could be due to this, could be due to that, could be due. That, again, shows you why you do various tests to point in what it is. Okay, so that's how we can finish today, is just by looking at the notes here. At the bottom two terms, you've got validity of a test. How accurate is it? Is it testing what it says it's testing? And the reliability of a test. Will the test show the same results on the same person again and again? It's a stability issue. So the terms to memorize here are validity, reliability, and then on the top of page 2 here, sensitivity, specificity. Know what those are. You will flip out any AUD audiologist with good handle knowledge of those terms, because retrocochlear pathology is the testing ground of tests, because eighth nerves tumors are hard to find. So when you and I are looking at an eighth nerve tumor, we'll do pure tone testing and we'll find an asymmetrical loss. That's a sign. We might do acoustic reflexes and find them absent, and they shouldn't be absent with, let's say, a 30 decibel hearing loss. They should still be present. If they're absent, that's a sign. Now you got two positive signs, and positive doesn't mean good. Positive means bad, right? You have two positive signs for an eighth nerve tumor. Then you might do speech recognition or speech discrimination, and it's abnormally poor for a 30 decibel hearing loss. That's a third sign. You go to yourself, you say to yourself, self, I've got my 3 signs of an eighth nerve tumor. I'm going to send this person off to the doctor. And now you're being a darned good HIS, because that's exactly what you're supposed to do. You're using the tests at your disposal to put the case together as best you can, and you're sending the person off to a medical professional who can hope to rule out an eighth nerve tumor. Only then could you see the client again for hearing aid type of health care, okay? There's my morning set of lies for you. All right, any questions?
Nope.
I do have a question on the quiz that's coming up.
Yes.
According to Canvas, we have Unit 3 and Unit 4 quiz due this Sunday. But we haven't even finished retrocochlear.
No, you haven't. And retrocochlear,
and then Unit 4 is the other one, the
pseudohypoacusis. Pseudohypoacusis.
That's Unit 4. And they both due Sunday.
That's kind of weird because I don't want retrocochlear to be due until a week later because we're finishing retrocochlear next week.
Right.
So no, I'll have to email Lynn Royer about that one. Thanks for bringing that to my attention because we can't have you quizzed on retrocochlear pathology until we're done talking about retrocochlear pathology. So I appreciate you bringing that to my attention. Right after this, I'm going to email Lynn Royer. Tell her, thanks for letting me know. All right. Adios, amigos.
All right.
Ciao for now.
Long and prosper.
There you go. Live long and prosper, as Spock would say in Star Trek. Adios. All right. Cheers.
Bye, Renee.
Bye.
Hey, see you, Renee. Yep.